Hello and welcome to today's talk on the cardiomyopathies. The definition and classification of cardiomyopathies is problematic. The commonest definition of a cardiomyopathy is that it is a group of diseases that are complex and heterogeneous. And anytime you see a definition like that, you know there's going to be large amounts of disagreement. If we go all the way back to 1980, when they were the first defined by the World Health Organization, they were called idiopathic diseases of heart muscle that were not any of the well-recognized causes of cardiac pathology. So that would include ischemia, hypertension, valvular defects, and congenital defects that cause murmurs at birth. But as the molecular revolution started to take over, by 2008, they'd come up with a whole new definition. And this is now defined as structural abnormalities of heart muscle with abnormal function. And then they add in this very difficult second part in which they say that is often genetic. And that leaves us two problems. The first is, what do you mean by often? And the second is, as we're going to explore, genotype, the defects you find in the DNA, only roughly correlates with symptoms in your patient. The other problem is it may or may not include the channelopathies, depending upon which group you study with. So what do we do in clinical medicine? We actually define this disease by echo. An echo is going to describe three basic phenotypes that form the clinical basis of almost all discussions. And if you can add in a molecular etiology, so much the better. The three clinical patterns seen by echo are: 1. Dilated cardiomyopathy. This is going to be dilation of the left ventricle with an ejection fraction of less than 40%. In other words, it is systolic dysfunction. Second, hypertrophic cardiomyopathy. This is left ventricular hypertrophy with preserved ejection fraction. Therefore, this is diastolic dysfunction, meaning there's problems with filling. And then the third and least common is going to be restrictive cardiomyopathy. And this is usually infiltrative type diseases in which we see a normal left ventricle that is associated with decreased filling. We prove it by showing that you see atrial dilation. It also is a disease of diastolic dysfunction. Let's take a look and go through these three categories. Dilated cardiomyopathies are usually described in terms of the hereditary defects, and these are going to be defects in the cytoskeleton protein. Here would be our cell membrane, and within that we're going to draw the contractile unit, which is going to be our sarcomere, the unit between two Z lines. The Z lines form the anchor for our actin protein, and actin interacts with myosin to form the contractile unit. The cytoskeleton proteins are going to be titin, the largest protein known in the body, which buffers the myosin, and then an anchoring protein, dystrophin, which binds to the dystrophin complex of the memory, and then out into the extracellular matrix to proteins like laminin. So the two classic cytoskeleton proteins are going to be titin and dystrophin. This is the same dystrophin that we find in Duchenne muscular dystrophy, and it is a major cause of death for those that don't die of respiratory distress in their adolescence. The usual patient with a hereditary cytoskeleton defect is going to present with congestive heart failure in middle age, left-sided shortness of breath, right-sided edema. To establish the diagnosis, one must do two things. We don't have a positive test. So first, it is a diagnosis of exclusion. And then second, because it is hereditary and usually autosomal dominant, we need a positive family history. Genotype is not the same as phenotype. So when we say diagnosis of exclusion, What are the usual causes of congestive heart failure? Because these are the diseases you have to exclude. Remember, 80% of congestive heart failure is going to be associated with ischemia. That's by far and away the commonest. Hypertension and valvular disease. And then we get to the much less common longer list, and probably in America the biggest group here is going to be our toxic causes. And the two commonest toxic causes are going to be alcohol and cocaine, but also our chemotherapy patients, for example, doxorubicin, are also cardiotoxic. After toxic causes, we go to viruses, infiltrating diseases like amyloidosis and hemochromatosis, and then various diseases of fibrosis we'll talk about when we come to the restrictive cardiomyopathies. Infectious myocarditis is probably the commonest identifiable cause of acquired dilated cardiomyopathy. And in the United States, this is going to be mostly due to viruses. And I only point that out to compare that to South America, where we have Trypanosoma cruzi, which affects the conducting system. When we talk about viruses, these are the so-called aggressive viruses, which means that they are systemic. And the common systemic causes are going to be Coxsackie B, adenoviruses, and Parvo B19. To recognize a systemic virus keys on the idea that it involves multiple systems. So they not only have respiratory systems, they have diarrhea, they might have joint pains, as well as their myocarditis. The finding that's most characteristic is that of a rash. So how do the viruses cause damage? First is direct injury by the virus. And that's always in counterbalance with the immune response and cytotoxic lymphocytes, which are also forcing cells into apoptosis. It is adaptive immunity, and so we're looking for chronic inflammatory cells. If we are forced to do biopsy to show this chronic inflammation, here's a picture of what that biopsy would look like. And what you're seeing in this picture is you're seeing the red structures here are the cardiac myocytes themselves. Then we look here and you can see this watery influence. That's going to be edema. All of these areas of blue dots are lymphocytes and macrophages of the chronic inflammation. From a non-pathology point of view, what you're really looking for is all of those little dark blue dots as the marker of chronic inflammation. The natural history is basically one of benign self-limited disease. But in some patients, this can go on for periods of days to weeks. And over that period of time, the inflammatory damage leads them to a dilated congestive heart failure. And that's how we end up in this category of disease. The problem is going to be, how do you make the diagnosis? Generally speaking, in everyday practical medicine, you're going to go looking for evidence of a systemic virus. And again, that's not positive, is it? That's going to be presumptive. The second thing you can go looking for is evidence of myocyte death. So that's going to leave you with the muscle proteins, creatine kinase, and troponin. But if you really do have to establish it, the gold standard is going to be the heart biopsy, in which you're going to see this inflammation scattered all through the cardiac myocytes. Now, obviously, that's not something you're going to do in a community center. That's something you're really going to leave to transplant centers that actually do heart transplants, and so they do many biopsies. Hypertrophic cardiomyopathy is overall our general model for genetic heart disease. The reason for that is that in 2/3 of these cases, you can actually identify the genetic abnormality. The definition of this disease by echo is that you can see the hypertrophy of the left ventricle. The presentation is usually asymptomatic. Either you're doing a routine physical exam and you come across an unexpected systolic murmur, or they're part of a family investigation. If you take these asymptomatic patients that you either have this unexpected murmur or a known family history, you're going to find genetic abnormalities in 1 in 200 of the patients. That's the prevalence. But if we come down and we take a look at our symptomatic patients, and here we're talking about congestive heart failure, chest pain because the intramural arteries get involvement of their smooth muscle hypertrophy, or because they have an arrhythmia. And this is classically going to be syncope related to the fibrosis. When we look at these patients, we're going to find genetic abnormalities in 1 in 500. So when we talk about this genetic to phenotype gap, you can see many, many more people have the mutations than have clinical manifestations of them. And that's one of the big problems in this whole area of disease. The pathophysiology, we see myocyte hypertrophy. And this manifests as left ventricular hypertrophy, which tends to be reasonably focal and most often seen in the upper septum. We're going to find the septal hypertrophy here in the upper septum. And if we were going to do a biopsy of that and see what the cells look like, we'd recognize that we'd have these fibers coming through, and they have this very abnormal architecture. It is called architectural disarray. There's all kinds of fibrosis associated with this critical area, which tends to be in the area of the bundle of His and the bundle branches. And that's probably the reason they are so prone to arrhythmias. The actual cardiac output shows a decrease of the stroke volume, and that's usually what they attribute to LVOT, which is left ventricular outlet tract abnormalities. They have more than just that. They have abnormal myocyte function, they get the arrhythmias, and they have decreased filling because of the abnormal chamber due to the hypertrophy, and that directly itself leads to a decrease in stroke volume. There are more than 1,500 mutations described in more than 10 different proteins, and most of these proteins are related to the contractile proteins. And here's our contractile unit, which are the Z lines. Actin proteins form their strength from adhering to the Z lines, and we have our myosin running along between them. In this we can see that we have our myosin heavy chain heads, which are going to be the interaction with the active sites in the actin. In addition to that, there are proteins that are going to be present that actually regulate the relationship of these structures, and this is going to be myosin-binding protein C. These two proteins form the majority of the mutations, but there are other proteins that we have to consider, tropomyosin and on it the troponin. So there's no strict definition of which of the proteins mostly involved. They're mostly going to be, however, the myosin-binding protein C and the myosin heavy chain. Genotype doesn't correlate to phenotype. You're going to find these abnormalities in 1 in 200 prevalence, but they're only going to have symptoms in 1 in 500. So there has to be clinical correlation of these mutations to your patient's findings. Whether they present with symptoms or not, the next step is always going to be the physical exam, and the characteristic finding is going to be a systolic murmur. Systolic murmurs are very common, especially in children. And so the problem is going to recognize which systolic murmurs are you going to refer to echo, looking for that asymmetric left ventricular wall hypertrophy. Normal murmurs increase with increased flow. However, in hypertrophic cardiomyopathy, we get a decrease whenever we get increased flow. And we get increased loudness whenever there is decreased flow. And that then becomes the critical finding of systolic murmur. They don't behave like the usual types. And the way you're going to increase and decrease flow then becomes a critical part of your maneuvering. So when we talk about inspiration, that increases flow on the right side and decreases flow from the lungs to the left ventricle. And so what we see then is the murmur is going to increase on the right side, but it's going to decrease on the left side. Leg raising increases the preload. So it's going to increase all murmurs except for hypertrophic cardiomyopathies. Squatting also increases the preload, so it's going to decrease the murmur in hypertrophic cardiomyopathy. Valsalva movers and standing both decrease the preload, so they're going to increase the murmur in hypertrophic cardiomyopathy. The key tests are going to be those that increase preload, leg raising and squatting, versus those that decrease preload, the Valsalva mover and standing up. The next thing you're going to send them to is echo, where you're going to be looking for that asymmetric septal hypertrophy. The natural history of this disease is the problem, because 1% of those that have ever had a symptom are going to die per year. When you're talking about a 10-year-old child, that's a very large lifetime risk. So as a general rule, all of these patients are put on beta blockers because protecting the heart from the stimulating effects of the sympathetic nervous system affects natural outcome. But if a patient has ever had a significant cardiac event like syncope, you're going to put in an implantable defibrillator. Restrictive cardiomyopathies have the definition by echo of having a normal left ventricle with decreased filling, which means that they're going to have a preserved ejection fraction. We don't really have a test to measure filling, so instead we measure the effect of that, which is bilateral atrial enlargement. Presentation is usually related to shortness of breath because it's a right-sided disease that gives them less volume to the left side, and it's going to be associated with right-sided edema. The pathophysiology has two basic problems. The first can be one of infiltration of the myocardial structures, and that's going to include things like fibrosis, which we find in the connective tissue diseases like scleroderma and rheumatoid arthritis. We could see fibrosis in hemochromatosis, where the iron induces fibrosis itself. And then the last of the big infiltrations is going to be amyloidosis. Usually this is secondary to multiple myeloma, but there are well-described familial conditions, the most important of which is beta-pleating of the protein transthyretin. There can be induction of fibrosis, secondary to things like radiation and medications. The problem with all of this fibrosis is that it leads to a decrease in ventricular filling. And the differential diagnosis is that of constrictive pericarditis. The diagnosis then is really one of exclusion. And this is going to include all of the usual studies of investigation, including EKG and imaging. But at the end of the day, the gold standard is going to be to do a cardiac biopsy and look for the actual process that's occurring in the myocytes. What should we learn in summary? The first is to understand there's no really satisfactorily universally described definition. The first thing is it's really a ruling out of the usual causes of cardiac disease: ischemia, hypertension, valves, congenital defects. The second is that it's highly associated now with genetics. And the third is that our definitions really clinically are being defined by echo. Dilated cardiomyopathies, these are going to be of our cytoskeleton, and they really force you into a differential diagnosis of congestive heart failure because this is a diagnosis of exclusion. Included usually in this is hereditary, understanding the genetics of the cytoskeleton proteins, and then the infectious myocarditises, which tend to be viruses in America. Hypertrophic cardiomyopathy are going to be diseases of our sarcomere proteins, such as myosin-binding protein C and heavy-chain myosin. Remember, there's this terrible problem that the finding of a genotypic mutation does not have to translate into a symptomatic patient. So while you're going to find mutations with a prevalence of 1 in 200, you're only going to find symptoms in 1 in 500. The diagnosis is that very characteristic septal hypertrophy overlying the architectural disarray and how to handle the physical exam of that systolic murmur and the fact that it gets quieter with increased flow. And then the last is going to be restrictive cardiomyopathy, and this is going to be the differential diagnosis of a restrictive pericarditis. So that brings us to the end of this tape. Thanks for listening. We'll see you next time.